And next, I'd like to invite Dr. Moriarty from Interventional Radiology. He's also actually a cardiovascular radiologist. He's done an MRI and CT imaging fellowship as well as interventional radiology fellowship, and he's really one of the most useful guys to know in the hospital because of the number of things that he can see and do. And he's going to talk to us today about CT angiography in adult congenital heart disease.
Thanks very much. And again, just say thanks to the organizers. It's been a great program, a great tribute to Dr. Child, and it's been really great for us in radiology and interventional radiology to have this very, very active and very high-end group to work with, because it's really pushed our limits. And hopefully I'll show you what some of those limits are and where we think we're going to be going with CT anyway. I don't really have any disclosures of note to do with this talk. But over the next 15 minutes, we're a disparate bunch here. We've got some surgeons, some physicians, nurses, interventionalists. And what I'd like everyone to be able to have at the end of it is to say, look, I know what the state of the art is in CT at the moment. I want to be able to know what CT can offer my patients with congenital heart disease. And then finally, if I'm thinking about ordering a CT in the clinic, what do I need to know for my own patients when they're asking me different questions? So quick bit of background, a few numbers about CT. We know that the population here in the States is a little over 300 million. It's been increasing at less than 1% per year. But CT usage has been increasing at over 10% per year over the last decade. So it really has exploded. And if you look at the fact that adult congenital heart disease patients, the numbers are increasing by about 5% per year, we're going to be seeing a lot more CT in this group. And that really has come about because we're now able to image much faster, much more reliably in people with really complex stuff going on. And imaging the heart is pretty much the hardest thing that radiologists do. Most people think we don't do much, but this is what we find the toughest. And it's because we're looking at very small structures, coronary arteries, 3 millimeters in diameter, things that curve in multiple dimensions, things that look the exact same as the tissue that surrounds them. This is what a non-contrast CT looks like. So in other words, it's a coronary artery beside more heart. It's not a lung tumor surrounded by air. It's difficult to pick out. You have to do something to change that. Also, things move in multiple dimensions. They move in 3 dimensions across the face of the heart. They move in 4 dimensions because the heart moves. So we have to find a way to up the game of CT, MRI, echo, whatever the imaging modality is, to be able to meet these challenges, which means that from a technical point of view, you have to optimize your spatial resolution to see the small things, your contrast resolution to pick out things that you want to see well, and your temporal resolution so that you can get things that are moving fast, like valves, like the heart itself. And this is where we've come from. Back in the day, it was röntgenograms, it was x-rays, guys who were very smart at picking up very subtle findings on multiple obliques. But CT began with this handsome guy in about the 70s. He ended up getting a guy called Jeffrey Hounsfield. He got the Nobel Prize in '79. And it was really what formed our speciality. But it took 5 minutes to get a grainy picture like this of one slice of the brain. And of course, that's completely useless when it comes to heart imaging. So it was only with increasing computer power, with increasing scanner technology, with first off spiral technology in the 80s and then multi-slice technology in the late 90s that we began to even kind of dream about seeing into the heart reliably. And that brings us to where the state of the art is now. And I think this is what you're going to need to have access to if you're thinking about doing CT reliably, accurately, reproducibly in people with adult congenital heart disease. And the reason that we need to be fast is because we need to be able to freeze the heart to reliably see small structures. To do that, you want to be able to image at one point in the cardiac cycle, not over the entirety, but freeze it at one point. And the physics of X-rays are that the attenuation, in other words, how much gets stopped, is the same whether you go from A to B or your X-ray goes from B to A. It doesn't matter. Using that fact, we're able to extrapolate the other 180 degrees of a full cardiac cycle. The smart people came around and said, well, if you have one X-ray tube that spins around and we can extrapolate 180 degrees, what if you have 2 X-ray tubes that come around at 90 degrees to each other? In other words, dual source imaging. Therefore, you only have to image for 90 degrees around the body. You're able to double your temporal resolution and image twice as fast. And that's where we're at now. People knew about this for years, but we didn't have the engineering capabilities to do it, because what you've got to do is you've got to build 2 CTs, one here, 1 to 2, another here, 3 to 4. And then you've got to have the engineering cojones to actually put 1.5 tons of CT and spin it at about 60 to 70 miles an hour around a patient, and do this 20 times a day so that it's feasible for you to pay $2 million for one of these scanners. So this is what a dual source CT looks like. You'll see some guy walking in the background now. This is what a live one looks like with the face stripped off it. And so these came on the market in 2006. They began to be refined in the US market 2007 and up to now, so that this is really what the state of the art is in CT technology at the moment. And doing that now, you know, it's fancy engineering. What does that mean? It allows us to image a lot faster. So if you look here on the left of the screen as opposed to on the right, the left of the screen is what conventional technology that's available throughout the country and throughout the world pretty much now would have, as opposed to what having a real state-of-the-art scanner would do. So if you look here, we're going to be able to scan from the top down straight away. Within 0.6 of a second, you get the entire chest. Meanwhile, it takes 6 seconds to do this. What that means is that you can image the entire chest reliably, freeze the heart. People who have arrhythmias, people who have high heart rates, people who can't hold their breath, all the patients that you're going to see every single day in a congenital heart clinic, you're going to be able to image much more reliably. And doing this then, it means that we now have the ability with CT to push the boundaries a little bit. We're not just seeing a single static image of something gray on a screen. You're able to do functional evaluation of motile structures with multiple contrasts in arteries, veins, in shunts, all the rest of the things that are complementary, as we've heard before, to echo, MRI, 3D echo. But these are just pretty pictures unless you're able to actually get something out of it. So, you know, if you're sitting there, what can CTA do for you when you're in the clinic? And what it allows us to do now is in people who have very small defects, things like small secundum ASDs, we can reliably see them. We're not, you know, doing the radiology fudge of maybe there's something there, maybe there's not. You can reliably call it in people with Eisenmangers. Small perimembranous VSDs, because you're able to freeze the heart, you can pick up small submillimeter abnormalities and confidently call them. From within the heart to a little bit outside, things like PDAs, reliably seen again. Partial anomalous pulmonary venous return, we've seen echo examples, we've seen MR examples. CT is no different. We can again pick up these abnormal connections and image this all within one breath hold. The difference between this and MRI is really how fast it is. And here in this same patient, imaging the sinus venosus ASD. You can also look at valve function. I think personally it does not meet up to the same stringent criteria you need for echo and now that we're getting with MR, but you can definitely do it. We're here with an Epstein's with large atrium, atrialization of the ventricle. We can see the bicuspid aortic valve in this patient, here in diastole and here in systole. And again, you can look at these in multiple planes, looking throughout whatever is going to help your intervention or your follow-up best. This view is particularly loved by a couple of people in this room because it shows the pulmonary valve, the pulmonary outflow tract, the relationship to the sternum, and here, this little dot here, to the coronary artery as well. So if you're planning to put in a melody valve, this allows you as a one-stop shop for full evaluation. But I think you're able to do all that with MR and with echo, where maybe CT has the improved resolution to help your patients at the moment is looking at coronaries. And I'm not going to talk about ischemic coronary disease where you're picking out, you know, lipid-rich plaque versus calcified plaque in small vessels, but all of that is very doable now on multiple platforms. But really where in the congenital heart world, people have seen this come into standard practice, I believe, is in anomalous coronary arteries. Here you can see a LAD coming off a right coronary cusp. In this case here, we've got anomalous origin of the right coronary coming with an intra-arterial course between the aorta and the PA from the left coronary sinus. and then its contralateral equivalent where you see it coming, the left coronary coming off the right coronary cusp. Again, very reliable, very safe, very quick information that can be gotten from a CT. And it's not just a single shot, you're also able to do functional evaluation, where here in diastole we can see that there's a little bit of compression of this anomalous origin of the right coronary artery, but in systole there's significant compression. This is obviously going to be more significant than just seeing a little bit of narrowing on a single phase of the cardiac cycle. This patient ended up being stented, and here to show you that we can follow up stents with CT where you're looking for neointimal hyperplasia or is it widely patent. Again, things that would otherwise require an invasive catheter angiogram. Some people in the room probably remember this case. This is a case of pulmonary hypertension with huge PAs causing a compression of the left coronary artery here, imaged initially with CT, then subsequently confirmed at angiography, at which time stenting was performed. And here on the follow-up, you can see that the stent is widely patent and is hopefully protecting the proximal left in this patient. Anomalies of origin are well visualized. We see anomalies, of course, things like myocardial bridges. If you see here, the epicardial coronary should lie on the epicardial surface, but in this case, the LAD comes down and bounces down underneath the myocardium for a limited distance. This is a myocardial bridge. Things like fistulae as well. Here you can see a right coronary fistula, which is a dilated, tortuous vessel coming down and dumping straight into the right ventricle, a coronary cameral fistula. And again, nicely seen, in this case, another fistula which comes down and goes into the coronary sinus. I don't think we'd be able to get as high fidelity imaging with MRI at the moment. There's also a very good correlate between CT and catheter angiogram. These aren't just pictures for picture's sake. That here you can see that this is a very tortuous, incredibly bendy fistula here off the left main, and we can see that the CT findings are exactly the same as the angiographic findings, again just from a different orientation at the time of intervention. Coronary aneurysms have been followed with CT for a couple of decades now, and in Kawasaki's patients we're able to see calcified aneurysms, see the little area of thrombus that may be of worry for distal embolization. Maybe this is going to change management. Again, different types of aneurysms. These are more fusiform than saccular, followed up again with, and here on the right coronary artery, followed up again with catheter angiogram. And then we're able to see within the coronary arteries things that even on catheter angiogram can be a real pain to pick up, things like small dissection flaps here within an aneurysm that again would be hemodynamically significant. So if that's the coronaries then, and we've looked at inside the heart, what else does CT offer? Well, CT gives you the ability to image the whole body in a very rapid fashion. This is a case of a patient who's pregnant. You can see the little kid down here in the breech position. Obviously, we don't want to be doing CT in people like this at all times, but this line that you can see coming down her aorta is a dissection. This is a 20-something-year-old, I can't remember, patient with Marfan syndrome with a type B aortic dissection beginning a classic location here, distal to the left subclavian artery. This whole scan would take in the range of about 2 seconds. With someone who's this pregnant, obviously they won't be able to lie flat in an MRI scanner for very long. So this is obviously the optimal, or one of the optimal modalities for looking at this patient. She did very well after I stented her. You can see here that she has complete resolution of her dissection flap and the kid was born and healthy and well. Coarcs, we've seen them on echo, we've seen them on MR, we can see them on CT. Here we can see the area of narrowing with big collaterals here in the internal mammary arteries in the retrosternal spaces. Things like interrupted arches where the arch comes off the pulmonary artery in this case, all visualized very well. You sometimes have to be a little bit creative. This is a case of Dr. Bulson's from earlier on this week where the patient has a Glenn shunt, has a Fontan shunt, and you want to be able to image both at the same time, separate circulations. The patient had a pacemaker, so therefore didn't want to do MRI. So in this case, we injected from both the arm and the leg, and you kind of tailor things to the patient. You do need to be a little bit savvy, and involving a radiologist who is interested in these things may be of benefit to your practice. So that's a kind of a quick run through of what the state of the art is with CT, what we're able to do with it with congenital heart disease. And you can see now that we're pretty much able to image wherever you want in the body with high fidelity, high spatial, high temporal resolution images to be able to pick up whatever the abnormality is. But you know, that's all well and good. What do you need to know when you're sitting in the clinic and you're thinking about ordering one of those? I think it's important to know what scanners are available. All CTs are not the same. If you are in a high throughput center, like a tertiary referral center that has good scanners and a good cardiovascular radiology section, yes, absolutely. If you're somewhere out in the boonies where maybe you don't have that, I think you can be left with poor quality imaging that is going to be really of no use to anybody. Contrast nephropathy, it's the exact same as with catheter angiograms. I'm not going to talk too much about it. Functional information. The next horizon on CT is going to be perfusion imaging, dynamic imaging, where we're able to give you very similar info to what you'd get off an MRI. And then the thing that people talk about a lot is radiation dose. And this is something that physicians, nurses, people who are thinking about a CT are cognizant of, but increasingly patients are worried about this. And they're worried about it because it's coming more and more into the public media about how radiation is going to give you cancer, and if you get a CT, you're going to die of that. So this is a controversial slide, because some people believe that up to 2% of all cancers in the United States at the moment are caused by CT. Some people do not believe that. I personally don't, but that is what is out there at the moment. And this is backed by good articles from the New England Journal. It is contradicted by very good articles from the New England Journal. It is very debatable, but you'll definitely get patients who will come into you and say, should they be having a CT because of this issue? The average dose from a CT coronary angiogram throughout the country at the moment is 10 millisieverts. What that means in real life is that as we sit here at sea level, we're getting about 3 millisieverts per year. If you live at Denver, Mile High, you're getting about 6 millisieverts per year. So you're talking about 3 years worth of radiation for a single CT coronary angiogram. As regards mammography, mammogram would be about 0.04. So it's a big jump for you to think about doing a CT coronary. But for a nuke med study, for a cardiac MPI, it's about 20 millisieverts. So it's all relative, but it is important. But I'll tell you that with newer technologies, with faster scannings, with what's called tube modulation, where we drop the radiation dose for everything except for the exact point that we want to look at in the cardiac cycle, where we can do things like ramping it up very quickly with high-end scanners, and then where we're able to modulate the amount of radiation that goes through dangerous areas like female breast tissue. You can now reliably, in a high-end center, aim for a routine CT coronary scan to come in at under 1 millisievert. And most people would say that this is a significant benefit then, because your risk of dying from a radiation-induced tumor, all the way from here at the top, which is what you get when you walk through an airline scanner, TSA, to down here if you're getting a Jamil 4-hour stenting, is, with 3 hours of that being Liverpool rant, is round about here. This is where a 10 millisievert CT coronary comes in. But if you drop that to 1 millisievert, it comes in way up here, just above the level of mammography and about 100 chest x-rays, which people would say is a very reasonable thing. So that's really a quick fly-through of all CT and where we are at the moment and how I think it will go a little bit in the future. And I guess we'll be having questions afterwards. Thank you very much.